Hello, my name is Ashish Bhamani. I'm one of the cardiology fellows at University Hospital's Case Medical Center. And today we're going to be talking about the detection of LVH for patients with hypertension for our point of care ultrasound series. The objectives of today's talk are going to be to review the indications for cardiac testing in patients with systemic hypertension and to learn to detect LVH on echocardiography. Just by ways of introduction, long-standing hypertension leads to the echo findings of left ventricular hypertrophy, left atrial enlargement, and can lead to aortic dilatation. Left ventricular hypertrophy can be detected with limited training in bedside ultrasound. We found that regression of left ventricular hypertrophy can occur with aggressive blood pressure management. The EKG, but not echocardiography, is recommended as sort of the initial evaluation for hypertension. However, if there is a suspicion of hypertensive heart disease, that is a recommendation for echocardiography. As we were saying, there are no absolute indications for echocardiography in patients with systemic hypertension as a lone diagnosis. The presence and severity of left ventricular hypertrophy may be indicative of the length and severity of uncontrolled hypertension. A bedside echo done to demonstrate end organ damage to a patient may be beneficial for motivating behavior change. For example, if they're not taking their medications for their blood pressure, showing them an enlarged left ventricle may help them realize that there is heart damage even though they feel okay. There are a couple of contraindications and cautions to keep in mind. Certainly, if the patient's too unstable for the exam, doing an exam just to assess for LVH is probably not the most prudent thing. A focused echo is not sufficient for patients suspected of hypertensive heart disease. You really should be getting a full echocardiogram in those situations. In mind, that left ventricular hypertrophy as a result of hypertension can sometimes be very difficult to distinguish from athlete's heart and genetic hypertrophic cardiomyopathy, as well as a number of other infiltrative processes, and often that requires assessment by an expert cardiologist. So just to keep those differentials in mind when you're looking for LVH. Our pre-procedure patient preparation includes sonographer introduction, where you introduce yourself to the patient. You want to make sure you identify the patient as the correct one, and then confirm with the patient the procedure you're doing and why you're about to do it. You want to drape and patient the position properly, and then position yourself while also keeping in mind special considerations for patients that are obese, patients who have COPD, and women in terms of how you might want to drape them properly. The equipment you'll be using is an ultrasound probe, a phased array with a small footprint with a frequency of approximately 3.5 megahertz. We'll be focusing only on the 2D images, as M mode and Doppler are not typically required for this situation. You'll also need to have ultrasound gel, towels, sheets, and disinfectants. Again, we'll be using tea spray or cavi wipes as a disinfectant and trying to avoid alcohol. When you consider detecting left ventricular hypertrophy by echo, you want to think about the image that you're acquiring. One of the most standard views is a parasternal long axis, or Plaque's view. You'll have the patient placed in the left lateral decubitus position with the left hand behind the head. You want to place a probe at the third or fourth intercostal space, lateral to the left sternal border, and you're going to rotate the marker dot so that it's pointing towards the patient's right shoulder, or approximately 10 o'clock. You may make slight adjustments to the probe, but in general the probe will be perpendicular to the chest wall, and you'll make small, finer movements to try to get the image in view that you'd like. Looking at this image here, in our parasternal long axis view, we have the left atrium, the mitral valve opening up into the left ventricle, the LV outflow tract with the aortic valve here, and again the right ventricle is in the anterior portion of the heart. When talking about left ventricular hypertrophy, the two main areas that we're going to be focused on are the interventricular septum, or IVS for short, and the left posterior wall, LPW for short. When we measure for LVH, you want to measure during diastole. So going more into the techniques and findings of LVH, you want to make the measurements at the mitral valve leaflet tips. You want to be careful not to include the chordae tendineae in the thickness of the LV walls, and the interventricular septum and posterior LV wall are both normally between 0.6 and 1.2 centimeters thick. What we see here is an example of the interventricular septum measured with this blue line here. This is approximately 1.8 centimeters, and the posterior wall measured with this green line here. This is also approximately 1.8 centimeters. So both of these walls are thickened, consistent with concentric left ventricular hypertrophy. So, a clinical case. A 50-year-old man with hypertension, non-compliant with his medications, presents to your clinic with a headache. He is found to have a blood pressure of 200/120, and his EKG shows voltage criteria for LVH. You perform a bedside echo, and this is the same example that we just looked at, but you can see that there's concentric left ventricular hypertrophy with thickening of both the intraventricular septum as well as the left posterior wall as measured in diastole. You perform a bedside echo and show him his thickened heart. When the patient is able to see the damage he is doing by causing the thickness of his heart to increase when he doesn't take his blood pressure medications, he tells you he understands now why you have been urging him to take his medications to try to get that blood pressure under control. Perhaps you've made some impact in his compliance in the future. Just as by way of disclaimer, the information provided here is intended to help supplement the clinical assessment in certain clinical scenarios and is not sufficient for formal diagnostic studies for billing purposes. Formal echocardiography, full or limited exams performed by certified laboratories are recommended when needed for this purpose. To summarize, an EKG is indicated for the detection of left ventricular hypertrophy in patients with systemic hypertension. A formal echo is not warranted for detection of LVH in patients with a lone diagnosis of systemic hypertension, but certainly should be done in patients where hypertensive heart disease is a consideration. Left ventricular hypertrophy is defined as an intraventricular septal or posterior LV wall thickness of greater than 1.2 centimeters when measured in diastole. A bedside echo to demonstrate left ventricular hypertrophy may help a provider understand the history of hypertension, and it may be an effective motivator for a patient non-compliant with blood pressure medications. Thank you.